I'm Manisha. I'm from VCU. I'm the resident on this paper.
Hi, I'm Chiwa Fan. I'm a neuromuscular neurologist at Virginia Commonwealth. So this was kind of born out of a cohort of patients that were misdiagnosed as seronegative generalized myasthenia gravis and was on a lot of immunosuppression for a long, long time. And so we tried to look back and see what were some pitfalls during that diagnostic process and what can we do better, especially since there are so many new immunotherapies out now that really open the options for seronegative patients.
And I think our biggest sort of outcome of this paper is trying to propose a new diagnostic algorithm that hopefully should help improve the positive predictive value of your diagnosis.
So some of the patterns that we noticed were for the folks who have negative electrodiagnostic testing, they end up being more likely, obviously, to not have seronegative myasthenia. Same thing for the treatment response. So if they're not reporting an improvement subjectively or objectively on the patient-reported outcomes, they're also less likely to have true seronegative generalized disease. So the part that I'm having a lot of interesting conversations today with other clinicians is how do you approach this, right? And how do we come up with an algorithm? And what's the proper way of trialing immunotherapy? And how many therapies do we try? And how do we know which one works? How do we know if it's true disease and we just don't have the right treatment? And how do we know if we got the wrong diagnosis?